in the brain. Now, let's focus on the stimulants. We have methylphenidate and amphetamine. We no longer have pemoline, which was taken off the market several decades ago because of the potential for liver problems, hepatotoxicity. And although it was rare, it was enough to warrant discontinuation of the medicine. But pemoline is still around in other countries, and sometimes is seen even in our countries in off-label generic forms. But we don't use it for ADHD any longer. The real news over the last 20 years has been in several areas. One is that we know that about 75% of people respond to one drug, one delivery system when it's tried. So about 3/4 of the people we try a drug with have a positive response. If you try both stimulants one at a time and their separate delivery systems, you can get up to 90% or higher response rate. So you never judge what the ultimate response rate is going to be from the one drug and delivery system that you may have tried. You may need to switch to another drug or even change delivery systems so that the Concerta osmotic pump does not work the same way that the pellet release soda systems work, does not work the same way that lisdexamfetamine, which is a prodrug, works, or the new Jornay PM, the delayed release stimulant. They all work somewhat differently in terms of their digestion, absorption, their psychopharmacologic profile, and as a result, people may respond to one better than the other. Try them all in succession, you get a pretty high response rate. So only about 10% or fewer of people do not respond to these drugs. Now, the average time that people stay on medication is about 6 months to 3 years. That's a problem. We're going to have to come back and talk about that because adherence to medication is a big difficulty. People often discontinue for a variety of reasons, despite the profile here of safety, of efficacy, and of duration. So sometimes our problem in practice is getting people to go back on their medication when they've stopped. I'll talk later about the reasons for this and what we might be able to do about it. But nonetheless, people are not staying on these medications lifelong, even though they could take them as long as they need them to reduce impairment. The second thing that's new in the research community over the past 20 years has been the ingenious creativity of pharmaceutical companies at finding ways to sustain the medication in the body for longer intervals of time. So when we look at the original pills, we have medications that lasted only 3 to 4 hours, 5 at most, but usually 3 or 4. And they were being used with children, so they had to be taken 3 times a day. Very annoying, especially at school, created safety problems as well. And you had this roller coaster ride of therapeutic blood levels across the day. Not a very good system. And so the drug companies went to work on creating mechanisms, engineering delivery systems that keep the blood level up as much as possible for long periods of time. Most of them 8 to 10 hours, some of the newer ones 12 to 14. So we now have, despite having, say, 2 drugs, methylphenidate and amphetamine, many different delivery systems getting into the body. So we have what I call the 5 Ps, the pills, the original immediate release medications, the pump, which is the Concerta osmotic Oros technology. I'll show you that in a moment. The pellet system, which is the time release little pellets of medication. We have Daytrana, the skin patch that you wear and absorb the medication through the skin. This is for methylphenidate. We have the latest prodrug, which is the lisdexamfetamine, commercial name is Vyvanse, which is very different from these other delivery systems I'll mention in a moment. And then, of course, we not only have the old immediate release liquid forms of methylphenidate and amphetamine, but now we have liquid versions of the sustained release forms of methylphenidate and amphetamine. And most recently, we now have the gummy their delivery systems, the chewable, dissolvable on the tongue versions of amphetamine and methylphenidate. And then a year ago, the latest invention is a delayed release, extended release form known as Jornay PM. You take this at night and it activates reliably 9 hours later, so that the child's medication is activating as the child is awakening, and the child is now getting a therapeutic dose during the early morning hours to improve early morning functioning, which we know from multiple studies was a major source of stress in families, even if they were using ADHD medications. This early period of 45 minutes to 90 minutes, when the other medications were being given to the child upon awakening, it took that long a time for the drugs to activate, leaving the child essentially untreated and leading to great distress during one of the most distressing times of the day, even for typical families, which is getting your children up and out the door to school while you are preparing to go to work, while you are also getting their siblings, if there are any, ready to leave as well. A very chaotic time with a terminating endpoint that also leads to distress. We have a time period here that we have to get you out the door. So it's interesting that a company chose to develop a delivery system that targets addressing that period of time in the morning, while at the same time the drug lasting about 10 to 12 hours or more across the day as well. So delayed release, extended release. Yet one more choice in our armamentarium of ADHD medications. If you're not familiar with the Oros pump, this is Concerta. It is a capsule with a laser drilled hole in it, and there are 2 chambers of medication. It's a methylphenidate paste or sludge, and this is an empty chamber here, and there is powdered methylphenidate on the outside. And when this is swallowed, the powder activates immediately, as it did in pill form, and that gives time for water to enter this chamber at a continuous rate. And as it does, it pushes down like a tube of toothpaste, if you will, or more like a plunger in a piston, and it squeezes the methylphenidate sludge out for a period of about 8 to 10 hours, sometimes 12 for some children. The dose of medication coming out initially is a little weaker. The dose of medication coming out later in the day is higher, because children need more medication later in the day than earlier. And that's because ADHD symptoms are worsening, and therefore we need more medication as well. At least that's the explanation for that. So what an ingenious device for getting a medication into and staying in the body as the capsule moves throughout the gut. And this is what happens. I mean, what you're seeing here, here's the blood level for methylphenidate 3 times a day. And that's that roller coaster we talked about. So you're up to therapeutic, now you're subtherapeutic, then you're back up, then you're down, then you're up. And what the Oros delivery system did is to release the medication and keep the blood level relatively continuous, so we don't have this up and down, and we stay in a therapeutic range of blood levels over time. Absolutely ingenious system. Okay, here's your pellet delivery system. This is like your Adderall XR, your Focalin extended release, and so on. And what happens is you have a capsule, you've got all these little pellets, they each have different coatings of medication on them. Each will dissolve at different times of the day. And so as this moves through the gut, these are dissolving at different time periods. And again, looking at the graph, you can see that they keep the blood level relatively even, particularly at midday or at mid dosing, when it would have become subtherapeutic if you were using a tablet form. The interesting thing about this pulse or sawdust delivery system is if the child has difficulty swallowing the capsule, it can be opened and sprinkled on, say, applesauce or yogurt, and consumed that way without altering the pharmacologic properties of the medication. This is your matrix transdermal patch under the name Daytrana, worn on the shoulder or buttocks with the medication being absorbed through the skin. Not used as often as I think the company had hoped it might be. About 1 in 6 people gets a skin rash from the methylphenidate and has to stop taking medication this way, but useful for some people who don't want to take oral medications, or for children who can't or won't swallow the tablet or the methylphenidate capsule, for instance. The next delivery system developed was the prodrug, known as lisdexamfetamine. You know it probably as Vyvanse. This is a very different delivery system that the FDA created a new name to describe, called a prodrug. And it works like this. You have a amphetamine molecule, in this case, and it is bound up with a lysine chemical so that it can't activate. The lysine locks the amphetamine so that there is no therapeutic action taking place until this chemical is put into an environment where there is an enzyme that can cleave the lysine off. And now the amphetamine can go to work. And that environment happens to be the human gut, and especially the lining of the intestine, which is rich in lysine, or in the enzyme that cleaves the lysine away and is able to convert the drug to amphetamine at a continuous rate as it moves through the gut. So here you see the cleaved components of the chemical. This was developed in hopes of reducing or eliminating the likelihood of amphetamine diversion and abuse, because you can't sniff it, you can't inject it, and get the same degree of effect you would get from oral consumption of the medication, or at least that's the hypothesis here. And so hopefully that reduces the street desirability of diverting this medication. Quite by accident, it was discovered after this was marketed that this is one of the longest acting of the delivery systems on the market, lasting from 12 to as long as 14 hours long. So although it is chemically similar to Adderall, it's an amphetamine, for instance, and it's a sustained release like Adderall XR, the way it's formulated, rather than being a pellet release delivery system, this prodrug delivery system seems to result in a smoother onset with somewhat fewer complaints of side effects, perhaps a longer window of therapeutic efficacy, and a more gradual, softer offset. So in my clinical experience, we are finding that many adults in particular prefer this delivery system to some of the others that come on very quickly, such as might Dexedrine or Benzedrine or even Adderall. So many delivery systems to choose from and to match to the lifestyle, the schedule, and the other characteristics of our patients. A third development over the last 20 years has been the recognition that stimulants are safe and effective when used with preschoolers. And although there were about 22 or more studies of preschoolers, including several that I did back in the 1980s and 90s, the federal government here in the United States, thanks in large part to being pressured by Hillary Clinton's presidential campaign, believe it or not, set about studying the safety and effectiveness of methylphenidate in a large sample, indeed the largest sample of preschool children entering a drug study, at that time anyway, was the PAT study, Preschool ADHD Treatment Study, a multi-site study involving 303 preschoolers, out of whom eventually 165 would roll over into the medication trial. These children were about 3 to 5.5 years of age. You can see the light, but 3 different doses of methylphenidate that were given 3 times a day to these children. And what was discovered is that A, the medication is effective. B, it's not quite as effective. So that instead of improvement in symptoms called an effect size of being about 0.7 up to 1.0, a slightly smaller effect size of about 0.4 to 0.8. So if you wanted to translate that into fractions, you're probably looking at about a 20 to 30% lower degree of improvement of an individual's symptoms. Also, a smaller percentage of the kids were improved. As I mentioned earlier, on average, about 55 to 60% of people who take a medication like methylphenidate are normalized. Here they found that 22% were normalized. So they improved, many more did, but they weren't brought into the normal range the way school-age children are. So both of these effects suggest that the stimulants are not quite as effective at the preschool age group, but they are safe, they are effective, and they do work to normalize some children, but they're less tolerated. So instead of 3% of children not tolerating the medication after age 5, it climbs to about 8% in the study, simply couldn't take the medication. Side effects were annoying enough to stop it, or about 1 to 2% of children can develop a psychosis, hallucinations. So in that case, they have to stop it immediately. And of course, the symptoms go away. Otherwise, the side effects profile was identical. There were no new side effects not discovered in school-age children. But kids were more likely to have them than school-age children were. And you can see here again, just in school-age children, there is some effect on growth, though it's temporary. There is some effect on failure to gain weight, and some effect on height. But no new side effects. So again, the profile is very similar to what we see in school-age children, just not quite as effective, and perhaps slightly higher incidence of side effects. Overall, the conclusion of the study, the methylphenidate is safe and effective to use with preschool children down to age 3, if necessary, if the child's symptoms are moderate to severe, and you've tried other interventions combined with it, such as behavioral parent training. Now, the effects of stimulants across the board, whether we look at children or adults, are numerous, and they have been documented in hundreds of studies. I'm not going to read these to you. You can read them on your own. I just wanted you to see the lengthy and diverse list of improvements that we see in group studies of patients taking stimulants to control their ADHD. Again, not everybody sees every one of these improvements, but these are what we document in the groups of people that have been studied across the research literature. So it's quite impressive, as we see here, as I move down this slide to show you the documented effects on social relationships, on awareness in sports participation, on reduction of exposure to punishment at home and in school, improved handwriting, improved working memory, improved organization, improved compliance with adult requests, reductions in accidental injuries and in death rates. Improvement in driving, improvement in auto accidents, improvement in suicide. All of this has now been documented in various analyses in the literature. And then, of course, now discovering that these medicines can be used when ADHD is a comorbidity with other disorders such as autism spectrum disorder and with bipolar disorder as well. So lots of improvements in individuals with ADHD from these medications. But again, they don't help everybody. and they don't help everybody to the same degree. And there are side effects that we have to contend with, which can be quite annoying. The 4 most common side effects documented across all of the literature are seen here. 50% rate of insomnia or delayed sleep onset by an average of 20 minutes to an hour. Loss of appetite, usually for the noon meal, affecting about half of the people who take it. Now, in adults, this is really not a side effect. Most adults don't mind having less appetite and therefore losing some weight. But in children, that would be a problem. About 20 to 40% incidence of headache and stomach ache. Most of these will dissipate within 2 to 3 weeks. If they don't dissipate, they can be dealt with through adjustments of the medication, of the dose, of backing up the timing of the medication, of changing to a different delivery system, or moving from a stimulant to one of the non-stimulants. So there are various ways of addressing the side effects. In lesser cases, we do see some other side effects that can be more annoying, a proneness to becoming emotional, sad, crying, to sentimentality, if you will, irritability, especially as the medication is washing out of the body. Less than 10% of children may develop a nervous tic or a worsening of their Tourette's syndrome, which is quite rare, but it can happen. When it does, in about a third of the cases with tics or Tourette's that were pre-existing conditions, stopping the medication results in a return back to baseline. So this is not a permanent worsening of the tic reaction. And even in those cases where tics are pre-existing, 2/3 of cases can tolerate the medication with no adverse effect on their tic disorder. So this is why the Tourette's Syndrome Foundation and many people who treat Tourette's are now encouraged to use medication where ADHD is present with someone with a tic disorder. There is a well-documented failure to grow. It's not a loss of height or a loss of weight. Children don't get smaller, they just fail to keep pace with the pediatric growth trajectories that would be typical for their age group. We're looking at a failure to gain weight of about 1 to 4 pounds in the first year, or about 1 centimeter of height during the first year. This may last 2 to 3 years, and then we see this dissipate. So there is no evidence of this continuing into adolescence or adulthood. And indeed, by adulthood, the research shows that there has been no adverse impact on adult stature, height, or weight from having been on a stimulant in childhood or adolescence. So these are short-term failures to gain. They're often mild, of no clinical concern unless you're dealing with unusually small children who are having trouble growing anyway, in which case you might want to institute the usual holidays of off medication on weekends and summer months. But in the average ADHD patient, where growth is not going to be as much of a concern, we do not recommend drug holidays anymore, because ADHD can be as bad on weekends and summer holidays as ever. And these are the periods where their life is threatened through accidental injury, through exposure to potential abuse, to possible death, to suicide, not to mention the psychosocial adverse effects of coming off medication, of impaired peer relationships, increasing stress within families, and so on. So for all of these reasons, we recommend that children stay on medication through weekends and summers rather than coming off, as was the custom back in the 70s through the 1990s now. So there was concern about 2 decades ago that the methylphenidate might be causing chromosomal damage in blood cells. That was never backed up or documented, and indeed inspection of the data showed that the data probably had not been analyzed properly, and there's been no further evidence that these drugs might cause cancer. There was concern that if pregnant women with ADHD took these during the first trimester or two, there might be an increase in birth defects or other problems of the child. There have been 3 population studies now that indicate, 2 of them found no increased risk of physical deformities, particularly in outward appearance. But there is one large study that did find a very slight but statistically significant increase in cardiovascular health and in the development of the heart. So some concern there, suggesting that, again, as is recommended anyway, pregnant women with ADHD may need to think about whether they want to stay on the medication or not. That has to be weighed against the adverse effects that can occur of coming off your medication while you're pregnant. And I've already mentioned what some of those risks would be when it comes to injury and so on. There are minor effects on heart rate and blood pressure of virtually no concern in the vast majority of people, unless they already have hypertension as a pre-existing condition, or they have a history of heart defect, heart surgery, or sudden death within their family. Even then, those are simply precautionary recommendations, because there is no evidence in population databases that stimulants increase risk of sudden death. And indeed, compared to the general population, people on stimulants experience less chance of sudden death. And we think that's because they are being monitored for their cardiac functioning, whereas the general population routinely is not. So the risk of death on stimulants was greatly exaggerated in earlier decades and not found to be evident in population-wide studies. There are many misconceptions that people have when they come into our clinics, and we suggest that they consider taking a stimulant. One is there a risk of addiction? This was a big deal made by social critics and one ADHD researcher in her research. This was Nadine Lambert. But all of the evidence subsequently examined shows that this is simply not the case, that addiction to a prescribed medication, stimulant in this case, taken orally, does not occur. You might develop a psychological dependence on it if you're using it at higher than typical doses, and you're using it to function and to stay up later, perhaps as a truck driver, or as Kitty Dukakis did during Michael Dukakis's campaign for the presidency. She became dependent, I believe, on her methylphenidate because of all the campaign stops and scheduling and so on in which she participated, but no risk of addiction that we can see from this. So there was also the concern that the individual might develop a risk later on for addiction to another stimulant, such as cocaine or tobacco. And we now have 19 follow-up studies showing no risk for later substance use or abuse when taking these medications. And indeed, a few studies suggest that if you stay on them through adolescence, the risk of turning to drug use and abuse is less than it would be in unmedicated ADHD individuals who have a higher risk of abusing drugs by virtue of being ADHD. No risk of seizure increase in children with seizures or epilepsy, except at very, very high doses, which of course are not used in clinical practice, but you can use these medicines safely and effectively in people with seizures who have ADHD. The only caveat is there's a slight increase in more side effects and a somewhat lower probability of a positive response. All that being said, the safety is there and they can be used if needed. I've already spoken about using the medicines with people with tics and Tourette syndrome. Used to be thought you couldn't do that, but research went on to show that clinical wisdom was wrong and that you can safely and effectively use these with tic-prone individuals. There, of course, is concern that we're overusing these medications. Overdosing or overuse implies that there's more drug being given in the community than there are cases of ADHD in the community. And we have not seen that being the case. The number of people within a community on medication is well below the prevalence of the disorder. If anything, when it comes to teens and adults with ADHD, the majority of people who would qualify for the diagnosis remain untreated with medication. But we're doing a better job in the last decade with children, where we have seen a flattening of the medication use, so that over the last decade, since 2011, there has been no increase in the United States in using stimulants with children, especially with boys. There's been a slight increase with girls, but they were underdiagnosed in previous decades. And the major increases continue to be in the segments of the population that were not being properly identified, diagnosed, and treated, and that is teens and especially adults with ADHD. So the evidence to date suggests that we're improving in our delivery, in our public health management of ADHD with medication. There, of course, is concern that the drugs are being given to the wrong people. That is, typical people are using them for performance enhancement, for getting preferential treatment in college or high school or in their job, for preferential improvement, that is. So some people, especially in college, feign having ADHD in an effort to get a medication prescription. Others may approach a college colleague and ask them to share their medication with them. So that's diversion from a legitimate prescription to someone who is using it illegitimately. And that is a problem on college campuses. Not as big as the media has made it out to be, but certainly something that clinicians need to concern about when they prescribe stimulants to college students living away from home. But otherwise, we are not seeing on a population-wide basis people given medication who don't have ADHD or a marginal case of ADHD. And what do I mean by that? I mean that there are a couple studies that have shown that there are people being treated with medication who are symptomatic and impaired, but might not qualify for all criteria in the DSM. And of course, journalists want to make a big deal of that. If you don't have the disorder, you shouldn't get the medication. But we know as clinicians that ADHD falls along a spectrum and that ADHD is a disorder that requires medication when suffering and impairment or harm occurs. And it doesn't matter if you do or do not meet all criteria for the DSM. We're not in business for making DSM diagnoses. We're in business to treat and relieve suffering, and diagnosis is a means to that end. But it's not the gatekeeper, and it's not the end itself. So I like to teach journalists and those concerned about these studies that clinicians in these studies are doing what they're supposed to do. Cases of borderline ADHD that suffer and have impairment should be treated, even if they are one symptom short of the requisite 6 or 12 needed for their particular presentation of ADHD. So let's not get neurotic to the point of silliness on requiring that treatment be predicated only on a diagnosis and never at any other time. Now, there was concern that giving stimulants didn't really improve academic knowledge or achievement. There was ample evidence that it improved school productivity, it improved grades, it improved behavior at school, it reduced punishment at school, it improved peer relationships at school. All of those are very well documented. But of course, the short-term studies that lasted typically only weeks to several months on average, were not able to document an improvement on academic achievement testing, the kind of thing you give children once a year to see how much they've learned in an academic year. But subsequent longitudinal studies, such as by Barbarese at Mayo Clinic and others, and my own, included or found that if you took the medication for several years, you did begin to see improvements in academic knowledge and achievement. It just took a while of the person staying on medication and being available for learning for us to detect it on these relatively crude measures of academic achievement. So even that criticism is now arguable and open to interpretation. So the stimulants are very, very safe and effective medications, but they're not meant for everybody.